Hello, future physical therapists. Today we're going to be talking about resilience in people with disabilities. And so that falls under the topic that we've been talking about in terms of psychosocial aspects of disability. So, our objectives today are to describe the psychological impact of physical disability and some potentially mediating factors that help contribute to resilience. We're going to identify some of the personal characteristics that are associated with resilience. We'll also talk about the impact of a supportive environment on resilience. We'll explain how resilience influences treatment outcomes in healthcare. And we're going to discuss a little bit of the PT's role in promoting resilience for our patients. So, the research on the psychological impact of disability, along with the experiences of our patients, have demonstrated that people with chronic disabilities are more likely to report poor life satisfaction. And so that kind of makes sense when you think about some of the consequences of disability, like the changes in roles for people with acquired disability or some of the reduced opportunities for people that have lifelong disability. There can be alterations in the person's ability to pursue their employment opportunities, educational opportunities, also social roles and hobbies, things that mean something to the patient. They may need to kind of alter that and find other things, other sources of meaning once their physical function becomes restricted by an illness or an injury. Because disability is associated with poor life satisfaction, we need to be concerned in that life satisfaction can be a predictor of longevity and psychological wellness. So for people that have poor life satisfaction, there's a history of premature mortality, and that includes mental health reasons, things like increased suicide risk. Also, people with physical disabilities are more prone to things like anxiety and depression. Life satisfaction is also positively correlated with health behaviors, and so people that are more satisfied with their life tend to take better care of their health, and this would include things like engagement in physical therapy and other aspects of rehabilitation, but also protective health behaviors, things that reduce our behavioral risk factors. So if you look at things like tobacco use, for instance, people with disabilities, particularly mobility impairments, are twice as likely to use tobacco products as their non-disabled peers. So, that tends to show some of the association between poor life satisfaction and some of these risk behaviors. So it kind of makes sense that if you value your life and you are satisfied with where you're going, you are going to make efforts to protect your ability to pursue what matters to you the most. In people with mobility impairments, let's talk about what the word resilience actually means. And so in general terms, resilience is the capacity to recover from extreme stress. It's also our ability to kind of bounce back. So it's the willingness to generate a positive response to adversity. When somebody is first diagnosed with an illness or an injury, resilience may take a while to develop. So we want to be as supportive as possible, create an environment that's supportive, connect the person with the new onset of illness or disability with other people who have been through similar circumstances and can provide some very practical advice for them. Some of the factors that are associated with resilience are personality. Some of us are just more prone to be optimistic, whereas other people tend to look more at some of the challenges that they face, and there's benefits and drawbacks to both, right? Somebody that's overly optimistic may underestimate challenges and may not be able to properly prepare. On the other hand, somebody that is so fatalistic in their viewpoint that they can't see the silver lining may be less able to or willing to engage in strategies that may help them along in terms of making things better. Other factors that are associated with resilience are independence and autonomy, a sense of self-reliance. You will often hear the term self-efficacy, which is your belief in your personal capacity to engage in activities that will make your life and your health better. And then the last thing we need to think about is a sense of purpose, and this could really change for people. If you think about athletes, for instance, their identity is very wrapped up in their sport. And so when we watch Crash Reel and you think about Kevin, his sense of purpose was very heavily tied to becoming an Olympic snowboarder. And when that was no longer possible because of his traumatic brain injury, he really needed to develop a different sense of purpose. And he did that in conjunction with his brother and his family, and that allowed him to move from a position of somebody who was no longer able to engage in their purpose as an Olympic athlete to somebody who has a tremendous impact on the lives of others as a motivational speaker. Some of the other individual factors, we need to think about whether or not genetics can affect resilience. We know that there are certain psychological factors that are tied to people's family histories. So it is possible to have a family history of mental health challenges such as depression or anxiety, and that might make things more difficult. There are other psychological factors. For instance, if somebody has struggled with other types of mental health issues such as post-traumatic stress disorder, and on top of that we get layered in a physical disability, that increases the person's burden, and it may affect their ability to be resilient and bounce back. There are cognitive and intellectual factors in general. When people understand their illness or disability a little bit better, they are more willing to engage in things that may help them along in their recovery. And so that speaks to our role as physical therapists. Very often when somebody has a new onset of a disability, they're not even sure what they will be capable of or what types of impairments might be permanent versus temporary, and what types of interventions might help them regain as much function as possible. So that's really where we come in. Also, age and prior experience with stressors, and this can kind of go both ways. Sometimes younger people lack the life experience to help put things in perspective, and so at whichever point you are in life, it may seem like this is an insurmountable challenge. Younger people are still developing a sense of confidence in their own abilities, and so that can make things more challenging. Older people sometimes have I don't want to say it's an advantage, but certainly resources that come with life experience. They've been through other challenges in the past. They know what works for them. They may have a history of successfully accomplishing goals despite adversity, and this all contributes to their level of resilience. At the same time, somebody who has not been successful in conquering challenges and who's older and maybe has a history of failure, that could create a negative impact as well. Sometimes we see this in patients when we're counseling them to have a change in health behaviors. For instance, somebody that is a tobacco user, if they've tried to quit on their own multiple times and they've been unsuccessful, and then you as a PT are trying to counsel them to get them to quit smoking or quit vaping, for instance, they have in their minds the fact that even though this is important to them, they've tried before and failed, and so that history of failure may make them somewhat less resilient. Disease type also impacts resilience, and there's kind of mixed research and mixed evidence on this. Some people have suggested that people with relapsing, remitting conditions may actually have higher levels of resilience because they know that even if they're at a point, a low point, for instance, somebody with multiple sclerosis who's having a flare-up, if they've had flare-ups in the past, they know that there's a good chance that this is going to get better with time. That's in contrast to somebody who has a progressive form of an illness that is likely to get worse over time. So that's one line of thought. There's another line of thought that says people with relapsing remitting conditions may actually be more anxious and less resilient because even during your high points, for instance, when you're doing well, there's this underlying fear that that's going to change. So you have this insecurity that you never know when you're going to get sick or when your functional abilities are going to decline, and that makes it harder to plan for the future. There are contextual factors, again, like the nature of the disability or the person's physical condition. There are life circumstances. So let's think about some of the resources that people might need in order to successfully manage a mobility impairment. If your life circumstances are such that you have good health coverage, for instance, and you have access to durable medical equipment, let's look at somebody who may have suffered a traumatic amputation. So somebody who's a lower extremity amputee, if they have good health coverage and they're in an environment where they have good access to care, yes, they've experienced a physical challenge, but they'll be able to see a prosthetist. They'll have a whole rehab team behind them. They'll be able to get a prosthesis. They'll have gait training. They'll be able to regain their mobility, ideally, right? But if your life circumstances are such, let's take a look at somebody who may have experienced a traumatic amputation in a third world country. So now that person probably does not have a lot of financial resources. They probably do not have health coverage. There may not even be a prosthetist or a prosthetics lab close to where they live. And so that person may never get a prosthetic. They may not even have a wheelchair. So their life circumstances are very different. And that, of course, will sort of play into how resilient somebody may be able to become. And so life circumstances kind of tie in pretty closely with available resources. Available resources are not only material resources, but things like social support and social networks. Disability can be very isolating for people. It can make you stand out. You're different physically. You may not have the same level of energy. It's hard for you to get around depending on where people are getting together. If it's not accessible to you, or you're too tired to go, or you lack modes of transportation, it may mean that this person's social network gets very, very small, especially in comparison to where it might have been before they had the onset of the disability. And then cultural factors. So we've kind of talked about this in class. There are different cultural views on people with disabilities, and how that disability is interpreted by the individual and the people around them can really make a difference in terms of resilience. And so if, for instance, somebody exists in a culture where their illness or disability is looked at as a punishment, or even something that is to be avoided by other people because they fear that it could be contagious, then that really has a different outcome in many different ways. So as you see, as we go over these factors, some of the traits are relatively fixed, right? And so for adults, our personality is pretty much relatively stable. And so any personality traits that somebody might have, and before they develop a mobility impairment, those are going to follow them through, and that can impact their resilience. But some of these other factors are modifiable, they're malleable. We can teach somebody more about their condition and about the options that exist for them. So things like cognitive and intellectual factors are modifiable. What we should be asking ourselves as healthcare providers is, what can we do to create a more supportive environment, to equip people so that they can be more resilient? So also, we said that resilience is not static. It is modifiable. It can fluctuate over time. So let's think about people with recent onset again. If you are treating somebody in an acute care environment who's had recent onset of a spinal cord injury, at that point in their rehabilitation process, they are going to look very different from a patient who is 1 to 2 years out, who has adjusted, who has developed alternate means of mobility like wheelchair use, being able to transfer independently, etc. So that person has adapted to the impairments that have been caused by the spinal cord injury. In contrast with somebody who has just had an onset of spinal cord injury, they may not be sure what is involved, what type of restrictions they face, whether or not those restrictions are temporary or permanent, sources of hope for them, depending on the types of adaptive equipment and their access to rehab. Where are they going? Their future becomes a little bit less clear to them, and that can create anxiety, of course. Also, there's the grieving process involved with the onset of the illness, and that can affect the person's resilience as well, whether or not they're able to successfully navigate the grief process to a point where they're able to accept it at least enough to move forward with their lives. So resilience fluctuates. It's also not an all or none construct. So people may be very resilient in some capacities and less resilient in others. What I mean by that is that you can see people that have great physical capabilities, notwithstanding of the impairment that they face. So we have people that are very high functioning, people like Paralympics, for instance, Paralympians rather. So you could have a person with bilateral amputations who is running track and field at an Olympic level. You can have athletes that play wheelchair rugby, wheelchair basketball, who are very, very capable. And so they may be very resilient from a physical standpoint. And then in secret, this person is turning to substance use to kind of address their depression and their anxiety, and we don't necessarily know about that. So you can be resilient in one aspect of your life and not have that carry over across the board. So it's not an all or none. Most importantly for us, from our perspective as healthcare providers, as I mentioned before, resilience can be cultivated. It can be encouraged. And so some of that has to do with helping the person start to evaluate their capabilities, also to come up with some type of explanation for themselves of the meaning behind why their life may have changed, even just accepting that there isn't any meaning behind it and letting that go enough to be able to move on. Life itself needs to still have a purpose, and that's really what helps motivate and drive us. If you think about yourself, your purpose as physical therapy students helps keep you motivated through a very challenging process of education. People with mobility impairments, there needs to be some purpose that motivates them to engage in rehab, to really struggle against whatever type of weakness or impairment might be brought on by the illness or the patient's condition, and want to engage with us in the rehab process. Some of the benefits of resilience: when people are more resilient, they have a reduced risk of psychological comorbidities like depression. They tend to report less physical fatigue, and so resilience can be energizing. Again, that sense of purpose. It has been shown to improve patients' treatment adherence, which makes sense, right? If we are asking you to engage in physical therapy and you don't see the purpose in it, how is that going to affect your outcomes and our ability to work collaboratively and develop that type of relationship between the patient and the clinician? People with resilience also tend to have better levels of physical activity despite impairments, and being resilient may help facilitate the rate of recovery. So people with resilience tend to have faster functional improvements. The research on resilience is very, very interesting for a couple of different reasons. So if we think about people with chronic pain, you can see where they would lose hope. If you're in pain all the time and there doesn't seem to be any interventions that are effective in reducing the amount of pain that you have to be able to work through that from a point of hope, right? What's the hope there? Is the hope that you'll get to a point where the pain doesn't interfere with your daily life versus being pain-free? And so people with higher resilience, even despite having persistent pain, they have lower levels of fear avoidance. I can kind of speak to this from a personal perspective with the CIDP. At first, when I developed the CIDP, people cautioned me, like, don't overdo it, make sure you don't exercise too hard, you're making yourself worse, stop pushing so hard. And then you become really unsure of yourself. Am I doing more damage? Like, is this going to give me more pain or more disability because I am motivated to try to move more? Well, when I spoke to the neurologist, what she told me was that I was not doing any permanent damage. That, yeah, if I push too hard, I may have a few bad days in there, and I may have some extra pain, but eventually it'll go back down to baseline. It's just that for people with CIDP, any post-exercise or post-activity recovery tends to take longer than for people without that type of condition or disease. Well, that took a lot of fear away from me, because if I'm not doing any type of permanent damage, then I can test my limits, right? Knowing, of course, that it could temporarily make matters worse, but I wasn't creating further disability from it. So lower levels of fear avoidance are really important, because sometimes in physical therapy we ask people to do things that are painful, right? If you have chronic back pain and you see a physical therapist, some of your exercises may increase your discomfort, at least temporarily. Also, in a related vein, people with higher resilience have less pain-related disability. So that's the ability or the willingness to try something despite having a high level of discomfort. So that's important as well, because just coming to physical therapy itself is kind of this leap of faith. If I'm hurting and I come to you knowing that it may temporarily make things worse, I need to be able to expect that in the long run, at least even if the pain itself doesn't change, I'll have an increase in function. In the long run, they may actually transfer into lower overall pain intensity. People with higher levels of resilience also have a greater likelihood of active employment. And again, speaking from personal experience, that has to do with my roles, right? And so my employment is very meaningful to me. It's also exceptionally rewarding. And when you have a sense of purpose and you have a high level of reward associated with your job, even if it's challenging to get up in the morning and get there, you know it's going to be worthwhile. And so you can see how this would factor in for higher resilience levels. So is this something that we need to think about then in terms of our treatment plans? We have physical agents and modalities that help people reduce pain. We have manual techniques. But do we start talking about things like chronic pain education for people so that they do understand that they're not doing permanent damage, that they can understand some of the neurological processes that contribute to chronic pain, so that they feel less fearful and better able to advocate for themselves and engage in treatments that will, in the long run, restore function. This is some of the research on resilience in people with Parkinson's disease. So we talked about how the response to degenerative and chronic conditions can be different than for people with acute onset conditions that have a fixed time period for at least optimal recovery. And this is Gail Wagnall's research. And what she found in people with Parkinson's disease was that the people that had higher resilience had lower reported disability levels, they had better physical quality of life, and they also had better mental quality of life. What was really interesting to me in reading her work was that you would think that the people that were less functional, that had the greater mobility impairments or more severe mobility impairments, would have lower levels of resistance. And what Dr. Wagnall actually found was that it didn't really matter. And so from a standpoint of resilience level, there was no correlation with disease severity. So even people that were severely disabled sometimes have very high levels of resilience. And so that shows that they are not necessarily cause and effect, that there are things that we can do to boost somebody's resilience level, and that the benefits of that are better quality of life. So how do we promote resilience? First of all, we have to be willing to discuss the person's perspective. So what's the perspective of our patients in terms of their situation and circumstances? How do they view things? And in order to do that in a meaningful way, we have to have authentic relationships with people. Our patients have to trust us enough to divulge their personal thoughts and to talk about really sensitive topics like being fearful and not being confident. Also, the sadness that's associated with change in roles. Being able to appraise their situation and circumstances in an authentic and meaningful way can sometimes help put things in perspective in a way that allows them to generate a more positive outlook. Some of that can be done through the use of support groups and social contacts. And again, going to a more personal perspective, for me, with having CIDP, talking to other people with CIDP and witnessing what they're capable of has allowed me to generate a positive outlook and optimism and realize that I still have a purpose in life, even though it's different than it was before when I was more actively engaged in patient care rather than having more of a teaching and research role. Future goal orientation also helps to give people that sense of purpose and develop that level of resilience. And so future goal orientation has to do with having realistic expectations about physical function and lasting impairments, but also about resources again, right? And so if somebody has a spinal cord injury and they are going to be confined to a wheelchair, what's their conceptualization of that? Do they know that there are different types of wheelchairs, that there are adaptations that can be made to their home and workplace that will allow them a greater level of mobility? When we think about disability, a lot of it is contextual. If you're in an environment with curb cuts and ramps and you're in a wheelchair, you're a lot less disabled than somebody maybe that lives in a rural area where wheelchair accessibility is a lot less. The last piece is really, really important. It's very important in physical therapy. It tends to be one of our main goals. And it's also very, very important from the standpoint of our patients. Each one of us, if you think about yourselves, don't you really treasure your independence? We all like to be self-reliant. We like to be able to do things on our own. And a lot of that is cultural. If you think back to the film that we just saw on Tuesday, I'll Push You, that's one of the things that Justin talks about, being in the wheelchair and being reliant on other people. He can't even get dressed or brush his teeth by himself, and how devastating that might be. But would you still consider Justin to be autonomous? And so think about that for a minute. What does it mean to be independent versus autonomous? So from a physical capacity, he's not independent in terms of his transfers and his ADLs, right? In fact, he's totally dependent. We would consider him max assist for dressing, max assist for transferring, right? So Patrick had to actually lift him from the bed to the wheelchair. He wasn't even able to use his arms to assist. That's a max assist transfer. That's completely dependent. Then think about his level of autonomy. This guy in a wheelchair who's max assist for all of his ADLs autonomously decides that he's going to leave the United States, go to Spain and France, and cross the Pyrenees Mountains with his friends on the Camino de Santiago. Does he have a strong locus of control? Would you consider him autonomous? And how do we promote that autonomy, that sense of self-reliance in our patients, even if they are physically dependent? So that can actually be a really big discussion for people. In a lot of ways, our patients can be, we call it autonomously dependent. That's the reason why we educate our patients in how something is performed, even if they're not performing it themselves. So for instance, in wound management, I have patients that are not able to change their own dressings. But I always make sure that if that person is cognitively intact, that they know the process and procedure to change the dressing so that they can instruct somebody else. That becomes really important in terms of continuity of care. Because if I come in on a home care visit on Monday and the nurse is supposed to come in on Wednesday and they can't, or they send a different nurse, the patient becomes my point of communication. And so if that patient is independent in being able to instruct the caregiver, we can be sure that the way things are going to be done is correct and consistent from one caregiver to the next. And it also gives the patient a sense of control. We have to be attentive to patient psychological outlooks. And again, that comes from having authentic relationships with people. When you guys did your presentations about conditions that complicate care, the group that talked about depression, depression is not something that is always overt, right? So there are very subtle signs, or sometimes there's no signs, and we have to be able to trust that the person has a deep enough relationship with us where they feel safe to share how they're really feeling. And so being able to recognize signs of depression, but also create a welcoming environment where patients feel safe enough to talk about those kinds of things with us, then allows us to offer resources and support for that person. Also, stress modulation. Having a disability layers an additional amount of stress on people. Think about the stress of daily living by itself. Just getting to school, right? The commute to and from school, getting to class on time, making sure that your laundry is taken care of, that you have groceries despite all the exams and assignments that you may have going on. Now think about doing everything that you do and also having to manage a disability. You have to make sure that you have all of your equipment where it needs to be. You have doctor's appointments that have to be scheduled, right? You have wheelchair maintenance, skin checks, medication regimen, all of these different things that also have to be managed at the same time as the usual stresses of daily life. So, are we training our patients to recognize the signs of stress and burnout and also to be able to determine an appropriate strategy for modulating that stress so it doesn't have a negative impact on physical and psychological health? This study looked at adults with spinal cord injuries, and like Gail Wagnall's study on people with Parkinson's disease, these researchers found that resilience was not significantly affected by pain levels. And so that's a little bit crazy to me because you would think that the more pain somebody has, the less resilient they might be. And that may be true initially, but clearly people have the capacity to learn and continue to grow despite the physical limitations that are placed on them. It also was not associated with the level of spinal cord injury or the extent of spinal cord injury, incomplete versus complete, and the types of functional impairments that somebody had. So, they are related, but at the same time, you can have, again, a high level of resilience and a low level of physical function. So some of the things that we want to think about in terms of resilience are, first of all, if we're talking about it as an outcome, right, we need to be able to have a baseline assessment and we need to be able to track it as people go along. So how do we measure resilience? We can't take a goniometer out or do a manual muscle test. So are there tools that we can use to measure resilience? And again, going back to Dr. Wagnall's research, she developed the Wagnall and Young Resilience Scale. So there is a patient-completed outcome measure that we can use to measure resilience. So that's a formal tool. Are there less formal tools that we might use to measure resilience? And do we need to think about our own level of resilience? Being a PT is challenging. Not as challenging as being a PT student, grant you, but still very challenging. We are seeing people at some of the most difficult times in their lives, and we have a lot of responsibilities that are placed on us from an emotional, a physical, psychological perspective, even from a spiritual perspective, as people try to make meaning out of some of these really adverse circumstances. So, how resilient are you? And so, if I ask you that, could you rate it on a scale from 0 to 10? What number would you give yourself, and why would you give yourself that number? If you think about it, does it also depend on the context? So, some of us might be very resilient in one regard and not so much in another. We could talk about what's your point of greatest weakness, right? And so what are the things that bother you the most, that you find the most challenging? And are you resilient in those circumstances? And then the last thing I want you to think about is, in your career as physical therapists, what are you going to do? What types of strategies might you use to help promote resilience in your patients? So hopefully you realize why it's important and you would accept that it is a modifiable trait. And with those two things in mind, how do we create resilience? Or how do we promote resilience is probably a better term. What can we do to facilitate it in ourselves, but also in the people that we work with? And we've been talking heavily about patients, but we should also think about caregivers because they have a tremendous amount of stress as well. If you have a spouse or a child or a family member who has an onset of a disability, your roles and your sense of purpose also change. All right. And so make sure that you check the discussion board. I will post some questions for us in terms of our book discussion on I'll Push You, and I will also post an announcement about being available for online office hours. Okay. Make sure you stay in touch, and I hope you all stay well. Thank you.